Hey guys, welcome back. So in this particular session, I'm going to start with the viral infections guide, right? So in the viral infection series, basically I'll be talking about main viruses. For an example, smallpox, then I'll be talking about the chickenpox, and then mainly I'll be talking about the measles, mumps and rubella, right? As they are very, very important. And we'll talk about some part of the vaccines as well as far as these viruses are concerned, right? So guys, let's start with these viruses. So the very first one which I'm going to take over here, that is the smallpox, guys. Yeah, so the very first one which we will be taking over here, that is the smallpox. Okay, smallpox, right? So if you talk about mainly the smallpox, guys, already it has been eradicated, right? So if you talk about the smallpox, okay, this is basically the variola virus. Okay, this is the variola virus, guys, right? And basically if you talk about the family of this virus, this is the poxviridae family. Okay, so family is the poxviridae, right? Family is the poxviridae. Sometimes it is kind of a factual data, and this is the double-stranded DNA virus, right? This is the double-stranded DNA virus. Okay, the double-stranded DNA virus. Here if you talk about the clinical features, right? If you talk about the clinical features over here of this particular virus, right? So what are the clinical features? The clinical features, some of them are like, for an example, here you might see the high grade fever in the patient. However, as it has already been eradicated from our country, right? And globally it has been eradicated as well as far as WHO is concerned, right? They have actually announced that in May 1980 they have announced that it has been globally eradicated, right? So however, just for the historical purpose I'm telling this. So it was showing the high grade fever, right? And then it was not showing the pleomorphism, right? What is the pleomorphism? Basically, like in the chickenpox, we are usually seeing the pleomorphism or the pleomorphic rash, right? What does it mean? For an example, in the chickenpox, if we will be talking about, right, there we are seeing different kinds of rashes at the same time. For an example, you might see the vesicular rash also, you might see the papules also, right? You might see the pustules also at the same time at different places in the body, right? But in the smallpox, either you will be seeing the pustules, either you will be seeing the vesicles, or either you will be seeing any other kind of rash, right? So at the same time, you will not be seeing the variations in the rashes. That is called as a pleomorphism property. So chickenpox is showing the pleomorphism property, but the smallpox is not, right? So now, if you talk about the smallpox, so it is not showing the pleomorphism. Okay. Next point over here is that it is basically showing the maculopapular rash first of all. Then it will be showing the vesicles, then it will be showing the pustules, right? So at one time, only one kind of rash will be seen on the body surface, right? So first of all, it might show the maculopapular rash. Okay, maculopapular rash. Then it might show the vesicle. Okay, then it might show the pustules, right? But at one time, only one kind of rash will be seen over there. Okay, if you talk about the pustules over here, they might be umbilicated, right? If you talk about the pustules, they might be umbilicated. Okay, if you talk about the vesicles over here, they will be deep-seated. Deep-seated vesicles might be seen over there. Okay, usually maculopapular rash, it will be resolves in within 48 hours. Okay, resolves within 48 hours. Okay, how will you be diagnosing this case? Particularly, if you talk about the diagnosis, we will be making the diagnosis by the lab confirmation. So it can be easily diagnosed by the lab confirmation. Okay, lab confirmation. Fine. Okay. Then it was actually who discovered the smallpox basically vaccine, right? So Edward Jenner. Okay, Edward Jenner in 1796. Okay, at that point of time only he discovered the smallpox vaccine, guys. Right, so thanks to him, smallpox vaccine. Okay, then you should know at what point of time WHO declared eradicated, the globally eradication, I mean. So WHO declared the global eradication, as I told you earlier as well, declared the global eradication of smallpox virus in May 1980. Right, in May 1980. That is also the important point which you might remember over here. And one more point I would like to highlight over here, that in India, if you talk about in India, basically in India, in the year April 1970, right? Or I would say in the year April 1977, I guess, right? So in April 1977, India declared the smallpox eradication, right? So India has been declared the smallpox eradicated country in the 1977, and finally in the May 1980, WHO declared the global eradication, right? Okay, so India has been declared right, smallpox eradicated country, smallpox eradicated country, right, in April 1977. Okay, right. Okay, so here what I'm trying to show you is that okay, so here what I'm trying to show over here, the difference between the chickenpox and the smallpox, guys. What you can see over here, that in the smallpox you are seeing the centrifugal pattern, right? In the smallpox you are seeing the centrifugal pattern. So this kind of pattern is basically called as the centrifugal pattern. Okay, now what do I mean by the centrifugal pattern rash? Centrifugal pattern rash means that it will be starting from the face but going to the periphery. What do I mean by periphery, guys? Periphery, I mean the upper limbs and the lower limbs, right? So firstly it will be starting from the smallpox, will be the rashes of the smallpox, mainly the maculopapular rashes or the vesicles or the pustules, right? It will be starting from where? From the face, and then it will be going towards the periphery. It might be the upper limbs and it might be the lower limbs as well, right? So basically in the trunk you might be seeing the rashes, but here and there only. Okay, guys. Now after this, once we have talked about the smallpox, right, they might be asking you about the smallpox vaccine. Okay, who discovered smallpox vaccine, and the pleomorphism pattern might be asked, right? And what about the centrifugal pattern and all? So centrifugal pattern I told you already, right? If you guys will if you will try to compare the rashes between the smallpox and the chickenpox, right, then what are the differences? In the chickenpox, as I told you, pleomorphism is seen. In the pleomorphism, what we are seeing, that basically different kinds of rashes might be present at the same time on the body surface, right? So here what we might see, we might see very small kind of rashes, then we might see very big kind of rashes, right? We might see some kind of vesicles might be present over there. Usually there are vesicles, but there might be pustules as well, there might be plaque formation as well. So different kinds of patterns of the rashes might be seen at the same point of time. That is main motto in the chickenpox, right? Telling you, right? But in the smallpox, what you are seeing, one kind of rash only. For example, here you can see the umbilicated pustules are present over here. Okay, so that is the basic thing between the smallpox and the chickenpox, which you might appreciate. Okay, guys. Then next one. Okay, so we have talked about the smallpox, guys. Now next virus which I'm going to talk about, that would be the chickenpox virus. Okay, that is the chickenpox virus. So let's talk about the chickenpox virus as well, guys. Okay, so many of the things you might have you might be knowing about the chickenpox, many of the things already. For an example, okay, so first of all, what kind of etiology we might see in the chickenpox virus? So it is caused by, guys, it is caused by the varicella zoster virus. Very important, VZV, that is the varicella zoster virus. Okay, so it is caused by what? Varicella zoster virus, right? Okay, simple point. Second point over here is that even after the recovery, right, this virus might be actually hiding itself in the sensory ganglion, and later on, whenever the patient will be having the compromise of the immune system, or I would say whenever the patient will be going in the immunocompromised state, right, so at that point of time this virus reactivation might happen and it can cause a herpes zoster in the patients, right? So that's why this is a very important point that can be asked. So this kind of virus, it might be remaining latent only, right? So it remains latent, or it will be hiding itself in the sensory ganglion, remains latent in the sensory ganglion, guys, right? Sensory ganglion. And whenever it will be finding the opportunity, what will be the opportunity of this virus? Opportunity will be the immunocompromised status of the patient, right? So whenever this virus will be finding the opportunity, okay, at that point of time it can reactivate, right? It can reactivate for years, right? It might remain latent in the sensory ganglion for years. Okay, so that is the thing basically over here. So reactivation of virus, it might be later on leading to the shingles formation. Okay, so reactivation of virus later might cause shingles, right? Might cause shingles formation. Okay, fine, guys, fine. Now after this, one more point over here. What is the period of communicability, right? What is the period of communicability over here? So period of communicability over here, that would be around, we should basically know that what about after the rash and what about before the rash? How many days, right? Communicability means that basically, before appearing of the rash, before the appearance of the rash and after the appearance of the rash, how many days the patient might actually spread this infection, right? So communicability. Okay, so over here if we talk about period of communicability, basically, so 1 to 2 days before the rash and almost around 4 to 5 days after the rash. Okay, so that is the thing over here. So I am just writing 2 days before the rash, 2 days before, and 5 days after the rash, 5 days after the rash. Okay, 2 days before and 5 days after the rash. Fine. And if you talk about the secondary attack rate, if you guys remember my previous videos, right, there I have talked about the secondary attack rate. That was an example of your proportion, right? So in the secondary attack rate, if you guys talk about, right, what would be the secondary attack rate of the chickenpox virus? That might be asked as well. SAR I am writing over here. SAR means secondary attack rate. That would be around 70 to 90%. That would be around 70 to 90%. Okay. Then, if you talk about the appearance of the rashes in the chickenpox, basically, they will be having the dewdrop on the rose petal, right? They will be having that kind of appearance. So, dewdrop appearance can be seen. Dewdrop appearance can be seen. Dewdrop appearance on rose petal. Dewdrop appearance on rose petal. That kind of appearance can be seen. Basically, when you will be seeing the vesicle is nothing but the fluid-filled lesion only, right? Small fluid-filled lesion. So, whenever that kind of lesion you will be seeing on the body surface, then you will be seeing this kind of pattern. That has been compared with this particular appearance, that is the dewdrop appearance, right? That will be classically seen in the chickenpox patients, right? The next point over here, they might ask you that, first of all, I told you that pleomorphism kind of pattern is actually appreciated in the chickenpox virus. So basically, first of all, the virus will be having, the formation of different kind of rashes, and later on, the virus will be having one stage that will be the pustule, and then pustule will be, later on they will be converting into the scabs, right? Scab formation will be seen. Now, all of the rashes are actually infective. But if you talk about the scabs, which is the later on stage, right? Scabs are not infective. In fact, whenever the patient will be showing the scabs formation on the body surface, at that point of time, we can consider this patient that, now this patient is not needed for the isolation, right? For an example, chickenpox virus patient, right? These kind of patients should be isolated because they might transmit the infection to others, right? But after 5 to 6 days of this particular virus, of this rashes, right, then scab formation start forming, right? I mean, the scabs start forming on the body surface of the patient. At that point of time, we can decide that yes, now the isolation period might be over for this patient, okay, and now this patient might be going outside, for an example, okay. So scab formations are not infective, basically, okay. That is my point over here. So scabs are not infective. Okay, so scabs over here are not infective in the patient. Okay, that might be asked as well, and that has been asked in the exams earlier as well. Okay, now next point over here which you need to know is the incubation period. Okay, so what is the incubation period? I'm just writing the IP, guys. What is the IP? That is the incubation period, and in this case we are just telling that this is around 10 to 20 days or 10 to 21 days, right? So that will be the incubation period for the chickenpox virus, right? And average we are saying about 14 to 16 weeks. Okay, guys. Next point over here which we need to know, that is what about the pregnancy? Now chickenpox virus, basically it can cause the congenital varicella syndrome, right? Basically in which trimester of the pregnancy? Mainly in the first trimester of the pregnancy. So if the pregnant mother gets this particular infection, that might be very serious, that might be very fatal for these kind of situations, because the chickenpox virus, basically it can transmit from the mother to the baby, right? In which trimester I am talking about? That is the first trimester only. Okay, so at that point of time, we might actually see the congenital varicella syndrome. Okay, so I'll be talking about that congenital varicella syndrome as well. What kind of features we might appreciate over there as well. Okay, so guys, in the pregnancy, basically in the pregnant situations, right, in the pregnant females, right, in pregnancy, what we might see basically in the pregnant females, okay, we might see the congenital varicella syndrome. So if this kind of pregnant females before 20 weeks, if they will be getting this particular virus, okay, it might be fatal for these kind of patients, right? So before 20 weeks, this particular virus has highest chance of transmission, okay, or I would say in first trimester, okay. So in first trimester, okay, or in fact up to 20 weeks, right, in first trimester, okay, this virus may transmit from mother to baby. Okay, from mother to baby, fine. So that can be very fatal. Okay, next point over here is, this kind of route which I am talking about, this kind of route is called as the transplacental route. Okay, actually in the mode of transmission we are saying that as direct mode of transmission. So this is the direct mode of transmission, or we can say this is the transplacental mode of transmission, right, to be very specific, right. So this kind of baby which you can see right now on your screen, guys, this is the congenital varicella syndrome baby, right. Here we are seeing that the head of the baby has been affected severely, okay, because mainly we are seeing the microcephaly in these kind of cases, okay. So in the congenital varicella syndrome, basically if you will be talking about, right, we are seeing the microcephaly, okay, and we might see the stillbirth in these kind of cases, okay. So the main feature which we may highlight over here, that is the microcephaly can be seen in these kind of patients, right. Okay, so that can be the feature, and stillbirth might be seen in these kind of persons or the patients, right. Okay, now guys, next point over here, that we are talking about the chickenpox virus right now. If we talk about the phases of the chickenpox, right, or I would say the stages of the chickenpox, right. So first of all, in the clinical features, I would rather say in the clinical features we might see some of the important salient points over here, right. So what could be those important salient points, right, in the clinical features point? Okay, so that might be, guys, first point over here, that would be your the phases, I would say, that is the pre-eruptive phase, then we are having the eruptive phase, and then we are having the post-eruptive phase, right. So in these kind of cases, in the pre-eruptive phases, okay, in the pre-eruptive phase, what we might see is that, right, in the pre-eruptive phase we might see the fever might be there in the patients, or some kind of coryza might be there, some respiratory infection can be there, okay. So these kind of things can be there. So fever might be there in these kind of patients, or coryza might be there. Coryza means like respiratory infection can be there, okay. So for an example, sore throat can be there, rhinitis can be there, okay. These kind of symptoms might be there. Second point over here is the eruptive phase. In the eruptive phase, basically there is the eruption of the rashes, right. So rashes will start to appear in these kind of in this particular phase, basically. So then you will be seeing about the second one over here, which we shall mention, that is your eruptive phase. That is your eruptive. In this eruptive phase, we are basically talking about the rash appearance, right. So rash will be starting, basically rash starts basically from where? It will be starting from the trunk region, okay. In the smallpox, I told you the centrifugal pattern as far as rashes are concerned, starting from the face and spreading towards the periphery, but in the chickenpox, what I am talking about is actually starting from the trunk, right, starting from the trunk basically, and then it will be spreading towards the whole body. So this is called as a centripetal distribution of rashes, right. This is called a centripetal. So in the chickenpox, you are seeing the centripetal distribution of the rash, and in the smallpox, you are seeing the centrifugal pattern of the rash, okay. So starts in the trunk and then it will be spreading towards the whole body and all. Okay, guys, understood? Okay, but it will not be infecting the palms and soles, okay. So except palms and soles I am talking about, okay. So except palms and soles, understood? Right. Next point over here, guys, I told you that first of all, maybe the papules can be there, right. Then maybe the maculopapular rash can be there, macules can be there, papules can be there, right. Then there could be the different kinds of rashes, vesicles can be there, right. Then pustules can be there. At last, you will be seeing that after 4 to 5 days of rashes, scabs formation will be seen, right. So after 4 to 5 days, you will be seeing that scabs formation are there. And please remember that these are not infective. Right. At this point of time, the patient no need to remain under the isolation, right, because they are not infected. So at this point of time, the patient will probably not transmitting the infection to other people, okay. Fine, guys, once we have talked about that, let's talk about the complications as well. Right. Okay, if you talk about the complications over here, okay, let's talk about the complications as well. Complications, as such, usually there are not many complications, but in some patient you might see, like in some serious patient, you might see the hemorrhages can be there. If in some patient already the pneumonia is there, that pneumonia might become very severe, okay. So that in those cases you might see the pneumonia in those kind of cases, okay. And basically in the children who are already having the influenza, or who are already having this chickenpox virus, varicella varicella virus basically, right, varicella zoster virus, they might be having the Reyes syndrome, right. However, that is rare only, if they will be taking the, non-steroidal anti-inflammatory drug, for an example, aspirin, right. So, very frequently asked question from the medicine side also. So, basically, if the patient is taking the aspirin, right, that's why aspirin are actually not advisable in the children's. Okay, but what we are seeing that, in the rheumatic fever patients, we are giving the aspirin. So, at that point of time, we need to understand that we should make sure that we are ruling out the viral infection in the children, because most of the times we are not able to, judge that basically this particular patient is having the viral infection or bacterial infection, at the first time. At the first place, if you are seeing the patient, you can't say much that it could be the viral or it could be the bacterial infection. It might be the bacterial as well, it might be the viral as well. So, at that point of time, better to not give the aspirin to such pediatric age group patient, because it might cause the Reyes syndrome. Okay, so what is the Reyes syndrome? Let's talk about that as well, guys. So, Reyes syndrome, however, it is not that common. It is right, it's kind of a rare only, but still we need to talk about this because very frequently tested in the exams. Okay, guys. So, here you can see the Reyes syndrome. What I mean is that, if you will be giving the aspirin to the pediatric age group patient, basically who is having the viral infection, in that point, at that point of time, it can cause the Reyes syndrome. Basically, in the Reyes syndrome, what we are seeing, the liver is getting damaged and the encephalitis component is there, right. So, hepatoencephalopathy can be seen in these kind of pediatric age group patients, right. So, here we are seeing the fulminant hepatitis can be there and the cerebral edema might be seen over there, right, due to that altered level of consciousness. Altered level of consciousness can be seen and the behavioral changes can be seen. Okay, these kind of changes might be seen in the patients, right. So, that's why be very careful whenever you are prescribing the pediatric age group patients, right. We should make sure that this is not the viral infection in the particular patient and we should not prescribe the aspirin in these kind of cases, right. So, we should prevent prescribing the aspirin in the pediatric age group patients, right. Okay, so how you can diagnose the chickenpox, guys, basically? So, it can be diagnosed basically by the varicella zoster virus DNA PCR. So, can be diagnosed by varicella zoster virus DNA PCR technique. Okay, fine. Now, next point over here which we can discuss, that is the prevention part. So, how we can prevent basically. Okay, so the prevention part over here, isn't it? So, basically in the prevention part, we are going to talk about the immunization part. Okay, in the immunization, we are going to talk about the two immunization patterns are there. That is, one is the active immunization. Either you can go for the active immunization, either you can go for the passive immunization, isn't it? So, in the active immunization, we are talking about the vaccine. We are talking about the live attenuated vaccine, right? So, first of all, let me talk about the A, that is the active immunization. Right. In the active immunization, basically, we are going to talk about this is the live attenuated vaccine, guys. First point which I want to highlight over here, that is that it is the live attenuated vaccine. Okay, be very clear with that. It is a live attenuated vaccine. Okay, as far as vaccines are concerned, right, I will talk about them in detail in the immunization chapter, right. But here, because I am talking about the viruses, okay, some points, small points, okay, I will be discussing over here itself, right. Okay, guys. So, if you talk about the active immunization, I am using over here, that is the live attenuated vaccine. Okay, if you talk about the strain over here, that can be asked, right. If you talk about the strain, that will be the OCA strain. Which strain I am using? That is the OCA strain. Okay, how you are giving this? You are giving this 0.5 ml of this particular vaccine, that will be actually injected subcutaneously. Okay, so what will be the dose over here? So, dose would be the 0.5 ml subcutaneous. Okay, what is the route of administration? Subcutaneous. Please remember that. Don't answer IV, I am giving IM or I am giving intradermal or something like that, please. So, that is the subcutaneous. Okay, how many doses you are going to give? You will be giving the 2 doses, guys. You will be giving the 2 doses. Okay, how you will be giving the 2 doses? Basically at 12 to 18 months, right. At 12 to 18 months, you will be giving the 2 doses basically, and then you might give the booster dose as well, as far as this particular vaccine is concerned, in about 4 to 6 years. Okay, so that is the thing over here. Now, second point over here, that is the second kind of immunization, that is the passive immunization. Okay, so let's talk about the passive immunization as well, right. Let's talk about the passive immunization as well. In the passive immunization, we are going to talk about again the immunoglobulin. Okay, not the vaccine over here, we are going to talk about the immunoglobulin over here. So, this is a varicella zoster immunoglobulin. Okay, or I shall write it as varicella zoster IG. Okay, what is this? Varicella zoster immunoglobulin. Okay, so here basically we are giving that within 72 hours of exposure. Within 72 hours of exposure of the virus, we are giving this particular immunoglobulin at the rate of around 12.5 international units per kg. Okay, so varicella zoster virus is immunoglobulin is actually given within 72 hours of exposure, guys. Within 72 hours of exposure. Okay, 72 hours of exposure at 12.5 international units per kg. Okay, so please remember that as well. Fine. Okay, next point over here is we should not combine the varicella zoster immunoglobulin with the varicella zoster virus. Oh, sorry, varicella zoster vaccine, right? So we should not combine these two things. So okay, so we should be, keep that thing in mind as well. Okay, so never combine the vaccine and the immunoglobulin. Okay, so varicella zoster immunoglobulin plus varicella zoster vaccine. Okay, this combination should not be given. This combination should not be given. Okay, this combination should not be given. Fine, guys. Next point over here, that what are the indications? Okay, in what kind of person we might opt for the passive immunization. So in the patients who are already immunocompromised, or the patients who are actually infected with the HIV, right, or the patients who are the pregnant females with having exposure to the chickenpox, right. So in those kind of cases, we might go for the passive immunization, right. We might go for the varicella zoster immunoglobulin. So in those patients we might go for it, right. So what are the indications over here? So we might actually it can be given in immunocompromised patients, right, immunocompromised patients, right, and might be given in the pregnant females also, right. So we can be giving it in the immunocompromised patients also, and we might be giving in the pregnant females as well, right. Okay, after that, what are the recommendations for the vaccine? Okay, let's talk about the recommendation as well. So here, guys, what are the age which we are targeting basically? So basically we are targeting the 12 to 18 months of age people, okay, or I would say basically the babies who are having the 12 to 18 months of age, right. So ideal age, if you talk about ideal age of giving this vaccine, that is a 12 to 18 months, right. Next point over here, that if you talk about the gap between the two primary doses, remember I told you, as far as active immunization is concerned, we are giving the two doses, right. We are giving the 2 doses at around 12 to 18 months, right. So here also I told you that ideal age is 12 to 18 months for the vaccine over here, right. But if you talk about the gap between the 2 primary doses, right, that would be around 1 to 3 months. Okay, so the gap between 2 primary doses, that will be around 2 primary doses, right. So that will be 1 to 3 months. Okay, so please remember that has already been asked. Okay, so that is MCQ. Next point over here which I want to highlight, that is what about the prophylaxis? Okay, what about the post exposure prophylaxis? For example, if some child got the varicella, okay, he is having the infection now, he is having the chickenpox virus now, okay, so if that exposure happens, then OCA strain vaccine can be given, okay, within 5 days of exposure. Okay, so OCA strain vaccine, which I told you in the active immunization part, right. There are 2 parts, guys. One is the active immunization, passive immunization. In the active immunization, we are talking about what? We are talking about the vaccine. In the passive immunization, we are talking about the immunoglobulins. Immunoglobulins I am giving to those patients who are immunocompromised patients, or who is already pregnant lady, okay, got the exposure to varicella, for an example, right, because it is very fatal in the first trimester, right. So that's why we should give the passive immunization over that phase. Active immunization we are giving to the 12 to 18 months of age. We are giving the 2 doses, and between 2 primary doses we are keeping the gap of around 1 to 3 months, right. And basically if some child got this particular exposure to the varicella, particularly within 5 days of exposure, we should administer the vaccine in these kind of cases, right. So basically I am saying that varicella zoster vaccine should be given within 5 days of exposure, to varicella, okay, understood that? So that is very, very important, right. That is called as the post exposure prophylaxis, because after the exposure you are giving this prophylaxis, right. So that is called as the post exposure prophylaxis, right. Here I want to highlight one particular diagram, right? Here I want to highlight one particular diagram, and that is this diagram, guys. In this diagram, what we can see basically, is, right? So this is kind of a revision, guys, Here what we are seeing, this is the varicella zoster virus. What is the pathogen over here? Varicella zoster virus. Okay, what is the course over here? You can see the vesicular rashes. You can see mainly what kind of rashes we are seeing, maculopapular rash, but this is the vesicle rash. Okay, vesicle means, I told you that dew drop on a rose petal. Dew drop on a rose petal appearance can be seen over there. So why we are seeing the dew drop? Because it is the vesicle. Vesicles are the clear fluid filled lesions. What are the vesicles, guys? What is the vesicle, guys? Vesicle is the nothing but clear fluid filled lesion. Okay, clear fluid filled lesions. If I am saying what is pustule, pustule means in the lesions there is a pus formation. Okay, that is called as pustules. Okay, anyways, guys. So if the lesion is smaller, we are calling that as vesicle. If the lesion is bigger, we are calling that as bulla, right? Okay, guys. So over here we are seeing that widespread vesicular rash we can see over there. Okay, as macules and rapidly becoming the papules. So maculopapular rash can be seen over there. Okay, with that we are seeing that various rash stages. So that is called as the pleomorphism pattern. Very nice. Okay, then we are seeing some of the complication might be seen over there. For example, bacterial superinfection, secondary infections might be coming over there, right? Meningitis can be there, cerebral ataxia, encephalitis can be there, but not that common. But what is very common is that this is the herpes zoster, that is called as the shingles over there, that might appear due to the reactivation, because I told you that this virus may latent in the sensory ganglions, and whenever they will be getting the opportunity, what will be the opportunity over here? And whenever they will be finding that patient's immune system has been compromised, at that point of time they might be getting reactivated, and they might cause the shingles in the patient usually. Okay, and they can cause the herpes zoster shingles, right? In the shingles, basically what we are seeing, at one side, these are usually unilateral, right? And one side, in the dermatomal pattern, they might be, there might be the involvement of the rashes. There might be the rashes at that particular time. Okay, here it might appear in this particular site also. That is the unilateral appearance. That kind of appearance will be seeing the herpes zoster ophthalmicus, right? Because usually they are covering the eye, right? The rashes will be covering this particular portion, unilateral portion, and that might cover the eye, and that might cover the whole face as well, and the head region as well sometimes, right? Okay. Treatment will be symptomatic, guys. Over here we are having the vaccine, and that is the Oka strain vaccine, right? We are having the Oka strain vaccine. Very nice. Okay, guys, what is the course of disease? I told you already what was the period of communicability. 2 days before, 5 days after the rash. Okay, so that has been mentioned over here, 2 days before and 5 days after the rash. What was the incubation period? I told you already, 10 to 21 days. Okay, that has been clear, guys. Look at the image over here as well. Okay, we are seeing that whole body might be covered, but basically it will be starting from the trunk region, and then it will be spreading toward the whole body, and this kind of pattern is called as centripetal pattern of distribution. Okay, this kind of pattern is called as centripetal pattern of distribution. Okay, guys, everything is clear, I hope. Okay, right. So I will be just removing this thing so that you can see clearly. Okay, so scalp involvement can be there, oral mucosa involvement might be seen as well, exanthem formation might be seen as well. Here you can see the vesicle formation. Okay, some fluid filled lesions. Okay, I told you what are the vesicles already. They are the clear fluid filled lesions. Okay, and here you might see some of the further symptoms, right? What kind of symptoms over here? For example, because of these rashes you might see the pruritus. Pruritus means severe itching can be there. Okay, along with that high grade fever might be there. Okay, I told you about the rashes already. Okay, that might be causing the headache, might be there, myalgia can be there, any other kind of viral infection, whatever symptoms are there, just same kind of symptom you will be seeing over here only, right? So not a very specific symptoms. Okay, only the pruritus you can see obviously because of the rashes appearance. Okay, so I think, guys, now the chickenpox is clear. Okay, now I am moving on to the one more virus, that is the measles. Okay, that is the measles again, guys, very important. Okay, so let's move on to that virus as well. So yes, so that let's talk about now the third one I'm going to talk about, guys, that is the measles. Okay, guys, what about the measles? Measles basically, this is the single stranded negative sense RNA virus. Is it DNA virus? No, it's not. It's the RNA virus. Okay, so this is, guys, this is basically, single stranded negative sense RNA virus. Negative sense RNA virus. Okay, RNA virus, and basically which family I'm talking about? I'm talking about the Paramyxoviridae family. Okay, I'm talking about the Paramyxoviridae family. Okay, guys, Paramyxoviridae family. Okay, fine. Next point over here, this basically, if you talk about the genus, this is a morbilliform virus genus. Okay, so if they are asking you, okay, however, nowadays these kind of questions are not coming. Okay, morbilliform virus. Okay guys, measles, if you talk about here, we are not seeing the carriers, right? And very few subclinical cases are there. Only the cases of measles which you are seeing in the community, those cases might spread the infection further, but as such we are not seeing the subclinical cases. What is subclinical case? We have already talked about the definitions of the carriers, subclinical carriers and all of these things. Okay, please go through that chapter so that you are clear with all those kind of definitions. Okay, so guys, subclinical cases means that these kind of patients do not show the signs and symptoms. But in the measles, if you talk about, these kind of cases are not present in the measles community. Okay, only the cases are present, and those cases can actually spread the measles. Okay, so which is a good sign for us actually. So these measles actually, it is not showing the iceberg phenomena. What is the iceberg phenomena, guys? I told you that the tip of the iceberg was showing the apparent cases, and the beneath part of the iceberg basically that was showing the inapparent cases. Okay, and I told you that what kind of diseases are showing the iceberg phenomena, what kind of diseases are not showing the iceberg phenomena. Please go through that chapter again, guys, for the detailed version, right? Okay, so guys, over there I told you that measles, tetanus and the rabies, basically these are not showing the iceberg phenomena. So over here I am talking about the measles, guys, and in the measles again I am talking about that this particular measles virus, this is not showing the iceberg phenomena because very few subclinical cases are found in the community. Okay guys, so over here we are seeing that there are no carriers, there are very less subclinical cases. There are very few subclinical cases, so does not show iceberg phenomena, right guys? Okay, next point over here is what is the secondary attack rate. What is secondary attack rate over here? Secondary attack rate is pretty high, that is around 80 to 85%. That's why I am writing it with a bold one, 80 to 85%. Okay, which is not a very good sign. Now next point over here, what is the incubation period, guys? What is the IP? That is the incubation period. Okay, incubation period, I will be writing the IP only. Okay, incubation period over here, that is around 10 to 15 days or 10 to 14 days I can write. So 10 to 14 days. Okay, 10 to 14 days. Now next point over here, that what about the trend over here? Basically if we talk about the winter season, I am talking about measles. Okay, during the winter season, okay, it is usually prevalent in the community. So for around January to April, okay, so it is prevalent in January to April season. It is prevalent between January to April season. Okay, commonly, right? That thing. Next thing over here, what is the period of communicability? Period of communicability means before the rash, after the rash. Okay, how many days are there for which the patient has to be isolated, right? So I would say that 4 days before rash, 4 days after rash. Okay, so what is the case over here, guys? For example, these were the rashes. Okay, these were the rashes. So 4 days before rash and 4 days after rash. Okay, in this particular time, the patient should be isolated. Okay, and this is the period of communicability. Okay, I hope you got this point, right guys? Okay, once you have understood this point, right, then what kind of children, basically the children are affected in this case, usually the malnourished children. Okay, usually the malnourished children are affected. By the measles. Okay, next point over here, how it is getting transmitted to the patients, right? So there are the measles cases in the society. Okay, how they can transmit it? With the help of the direct mode of transmission, that is the measles. This is the respiratory kind of infection, right? With the measles only, many of the viral infections, how they are getting transmitted. For example, COVID-19 also, it was getting transmitted with the droplet. Okay, direct transmission. Okay, so that is the case over here. So here also the mode of transmission would be the direct. Okay, and that is through the droplets. Okay, that is through the droplets. Okay, so mode of transmission would be the droplets. Okay, this is the direct mode of transmission. Okay, which is the direct mode of transmission. Okay, so I'm just writing droplets over here, which is the direct mode of transmission. Okay guys, once we have understood this, then we might talk about the stages of the measles virus. Okay, so let's talk about the stages of the measles virus now. So if you talk about the stages of the measles virus, okay, again we are talking about the 3 stages, guys. Very simple one. First one is your prodromal stage. Okay, so first one is the prodromal stage. In the prodromal stage, guys, again we are seeing that fever might be there, coryza might be there, cough might be there, these kind of symptoms can be there, okay, in the prodromal stage, So what kind of symptoms we are expecting in the prodromal stage? Basically the fever, high grade fever might be there, the coryza might be there, okay, the running nose can be there, sore throat can be there, okay, these kind of things can be there. In some patient diarrhea might also be seen, okay. So these are some of the prodromal symptoms, okay, and usually they are lasting in between from around like 3 to 5 days, okay. So it lasts for around 3 to 5 days, okay. And what would be the symptoms? Basically the symptoms can be your for an example, the fever can be there, okay, with that coryza can be there, coryza means like sore throat can be there, running nose can be there, okay, all these kind of symptoms, right. In some kind of patient diarrhea might also be seen, okay. So these are some of the non-specific kind of symptoms which you can see over here, right. By the way, triad is seen in the measles basically, okay, a very popular triad. That is basically in this kind of triad we are talking about 3 particular components. That is, one is the cough over here, so coughing can be seen in these kind of patients, right. Then coryza can be seen, and then the conjunctivitis, okay. So I will be just mentioning this particular triad over here itself, right. So what is this particular triad? Triad is very simple, guys. So patient might be having the cough, the patient might be having the coryza, and the patient might be having the conjunctivitis, okay. So this triad might be seen over there. And again, guys, what I'm talking about, this is the measles, okay. So once you are clear with that, cough, coryza, conjunctivitis, okay, very popular triad is seen in the measles again, okay. Now one very particular kind of rashes can be seen in the buccal mucosa, guys, right. What kind of rashes I'm talking about? That is the Koplik spots, guys, okay. So Koplik spots are seen, okay, I'm just highlighting this because it is very important, has been asked multiple times. So Koplik spots, guys, is seen in the measles, basically in the buccal mucosa region, okay, in the buccal mucosa region. These are kind of a small whitish kind of spots which you are seeing in the buccal mucosa, right. Here you are seeing those kind of rashes, right. So here I want to just highlight that, okay, just highlighting that kind of rash over here, right. So for example, you are seeing these kind of rashes, right. You are seeing these kind of rashes. These are the white kind of rashes present over there, okay, in the buccal mucosa region, that would be seen near the first and second molars, okay. So guys, Koplik spot, let me mention them over here itself. In the Koplik spot, basically near the first, second and molars, okay, near the first or second molars, right, okay, near the first or second molars, right, you are seeing the small whitish spots, right, small whitish spots in the buccal mucosa, right. So that is your Koplik spots which are actually seen in the measles, right. Now next thing over here, so these are very pathognomic of the measles, right. If these kind of spots can be seen in the buccal mucosa, then you are spot on and your diagnosis is very clear in your mind that you are talking about the measles, you are seeing the measles, right. Usually these kind of rashes are seen before the rash. I mean, these spots can be seen before the rash, that is 2 to 3 days before the rash. So these can be seen actually, these can be seen 2 to 3 days before the rash, 2 to 3 days before the rash, okay. So that is also very prevalent feature, okay, prominent feature, I would say. Then next one you can mention about, that is the eruptive phase, okay, or eruptive stage, okay. Here I have talked about the prodromal stage, this is the eruptive stage, okay, eruptive stage, okay. Again, in the eruptive stage, what you are going to talk about, basically here we are going to talk about the appearance of the rash, start of the appearance of the rashes, right. And basically these rashes are the maculopapular rash again, guys. So here also we are going to talk about the maculopapular rash appearance, okay. So basically it will be extending from which region, okay, it will be extending from this particular region, behind the ears. So post auricle, these are the auricles over here, present over here. So behind the auricles, basically the rash will be starting from here, okay, and then it will be extending downwards, towards the trunk, basically to the trunk, and then it will be going towards the whole body, right. So guys, what is the patterns of maculopapular rash, right, maculopapular rash, which will be actually beginning from the post auricular region, right, post auricular region, and then from there it will be extending downwards, right, extending downwards, and mainly it will be going through the trunk, and then whole body, basically I want to talk about, right. Okay guys, once we are clear with that, then we shall move on to the one more stage, that is the post-measles stage, right? That is the post-measles stage. So one more stage over here which I want to highlight, that is the post-measles stage. So first of all is the prodromal stage, then we have talked about the eruptive stage, then we are going to talk about the post-measles stage. Okay, so what is the post-measles stage? In the post-measles stage, we are basically in the post-measles stage, we are basically seeing that in some patients there might be this is basically post-measles, means after the measles you are talking about. So some patient might be developing, might be having the experience of the weight loss. Some patient might be having the loss of appetite. Some patient might be having the generalized weakness. Some patient might be having the diarrhea development. Okay, diarrhea might be there. So these are some of the cases which can be experienced by some patients, right? So there could be the weight loss in some kind of patient. There could be the diarrhea in some kind of patient, right? Generalized weakness can be there. Okay, so these are some non-specific features might be seen in some patient, right? Might be seen, I said might be seen in some patient, might not be seen as well. Okay, what are the complications which some patient might complain of? So what are the complications as far as measles are concerned, right? So very common complication which you need to understand, guys, which you need to remember for your exam, very important, that is the otitis media, inflammation of the middle ear basically. So that must be known by you. So that is the otitis media, guys. Otitis media, this is the most common complication. Please understand that this is the most common complication, guys. Okay, after that, yes, some kind of patient might be having the pneumonia development. Okay, so pneumonia might become very severe in some cases, and that is the most common cause of death, guys. Okay, that is the most common cause of death. Becomes very fatal in some kind of cases, right? Okay, in some rare cases you might see the subacute sclerosing panencephalitis. However, it is rare, but examiners love this, so that's why I'm just mentioning over here. So SSPE, this is the rare, however, but can be asked very frequently. It has been asked multiple times. Okay, so that's why it's worth mentioning. It's worthy that I will be mentioning it over here as well. So that's why SSPE is the main complication. That is a rare complication, but it's very important to know for the exam purpose, right? So here I have just compared the chickenpox and the measles rashes over here. In the chickenpox we have already talked about, right? There also we were talking about the fever. Here also we are talking about in any viral infection you might talk about the fever. Fever is not a distinguishing feature mainly. It's kind of a non-specific feature. Okay, so in the exam they don't bother you. With these kind of feature. Non-specific symptoms, nobody gonna ask you, right? So fever, yeah, this is kind of a common sense thing. So yes, headache might be there. Over in the measles as well. In the tiredness or fatigue, these are the non-specific features. The main point over here is red spots first appear on the chest, face and back. Okay, mainly in the trunk region, I mean the chest region, this region, and then back region. This is the trunk region, right? So in the trunk region, centripetal pattern of distribution I told you in the chickenpox, whereas in the measles we'll be seeing that post-auricular region. I told you from the post-auricular region to be extending towards downside, right? And because the trunk and all of this. So red blotchy pair first appears on the forehead and all, right? And basically in the post-auricular region. Please remember that, right? Red inflamed eyes. I told you that conjunctivitis might be seen over there, right? Conjunctivitis might be seen over there. I told you about the triad as well. That is the cough, coryza, and conjunctivitis, right? Very nice, guys. Running nose can be there, yes. Sore throat and all. Koplik spots, I told you, near the first and second molar. Whitish spots can be appreciated in the buccal mucosa, right? That can be seen in the measles, right? Very nice, guys. In the chickenpox, I already talked about decreased appetite. That can be seen in the measles as well. Complication part in the post-measles stage, but still, spots turn into the blisters, okay, and then it will be turning into the scabs as far as chickenpox is concerned. But the scabs are not infective, right? Okay, and that is a sign that yes, the isolation period can be over as far as chickenpox is concerned if you are seeing the scabs, because they are not infective, and now the patient will not be transmitting the virus properly. Okay, guys, once you are clear with the chickenpox, measles, and the smallpox, which we have talked about earlier as well, right? In the measles, let me talk about some other things as well. For example, immunization part or the vaccines part, right? In the chickenpox, we have talked about that. Now let's talk about the measles part as well. Okay, so in the measles, guys, what about the management? Okay, before management, let me talk about some few things as well. So how you can diagnose the measles? Basically, it can be diagnosed clinically on the basis of rash pattern and all of those things which you can see. Alright, so diagnosis is clinical, so can be diagnosed clinically, right? Can be diagnosed clinically usually, and we don't need much investigation in this case. But still, if you talk about the gold standard test, so PCR is the gold standard over here, right? So PCR is the confirmatory test, or I would say the gold standard test. Okay, so confirmatory or gold standard, right? That is your PCR test, as it is prominent or gold standard or the best test, confirmatory test in most of the viral situations, that is the PCR test only. Okay, fine guys. Then let's move on to the immunization part now. That is very important over here, right? Okay, so what about the immunization part? Here I'm going to talk about mainly starting with the management, okay, or the treatment. Viral infections we do not have much treatment over here. Symptomatic management usually we are doing as far as viral infections are concerned, but still, okay, so treatment we don't have, but still we are gonna talk about the prophylaxis part, right? So only prophylaxis can be done. As such, symptomatic management you will be doing only prophylaxis and symptomatic management. Prophylaxis and symptomatic management you will be doing over there, as you are doing for other viral infections as well. Symptomatic management. For example, for the dengue, what we are doing for the dengue fever, right? We are doing the symptomatic management only. Provide the fluids to the patient, okay, and whatever symptoms they are having. For example, if they are having fever, provide the analgesics for the pain purpose. For the fever person, you can give the antipyretics and all, right? That is the symptomatic management. Okay, so if you talk about the prophylaxis part, right, one very important prophylaxis we might talk about, that is the vitamin A prophylaxis, because that is having the role in these patients, right? So vitamin A prophylaxis we are giving in the measles patient. If you talk about the vitamin A prophylaxis over here, we are having the age patterns over here: less than 6 months, 6 months to 1 year, and more than 1 year. Okay, so what you will be giving in these kind of cases, right? So if you talk about less than 6 months, then you will be giving basically 50,000 international unit, right? If it is 6 months to 1 year, then you will be giving the 1 lakh international unit, right? So you will be giving the 1 lakh international unit. And if it is more than 1 year, then you will be giving the 2 lakhs international units. That is about the vitamin A prophylaxis in the measles patient, okay, and that has been asked in one of the exam, right? Okay guys, next point over here, that is the measles vaccine itself. So, right, so that is about the measles vaccine itself, right? So the measles vaccine or vaccination, right? If you talk about the measles vaccine, guys, over here, let me tell you, what is the strain. For example, in chickenpox, I told you we were using the Oka strain. Over here, we are gonna talk about. Over here, we are using the Adamonston Zagreb strain. Okay, please remember the strain as well, because they might ask you. Okay, Adamonston Zagreb strain, right? So next point over here, that is, is it a live attenuated vaccine or it is a killed vaccine? Okay, what kind of vaccine it is? Please remember that this is the live attenuated vaccine, as we have talked about in the chickenpox virus also. That was also the live attenuated vaccine. This is also the live attenuated vaccine. This is the freeze dried vaccine. It means we need the diluent to reconstitute it. This will be freeze dried, means it will be coming in a powder form. So you will be having some kind of solution with it, and you will be actually mixing with this particular solution, right? And usually that solution is the distilled water, right? So freeze dried vaccine, okay, which can be reconstituted with okay, with distilled water, okay, distilled water. So what is the reconstituent? Distilled water, okay. So here you are having the measles vaccine in front of you, right? And you are having that in the powder form, as most of the antibiotics are coming in the powder form, okay, and we are actually mixing the normal saline, mixing it, and then we are injecting the patient, right? That's how I'm saying that, the measles vaccine also, right? First of all, it has to be stored at a suitable temperature. I will talk about that, right? That is +2 to +8 degrees Celsius, okay, that should be in the fridge only, right? But here what I'm talking about, that is a freeze dried vaccine, okay. With that, they will be giving the distilled water, okay. So you will be taking the distilled water and you will be injecting into the vial, right? And then you will be mixing it, right? That is called as the reconstitution. So reconstitution must be done with the distilled water, right? Okay guys, once we understood that, right, the next point over here is that we might be giving the measles containing vaccine, right? That is the MCV, right? In the measles containing vaccine, we are talking about, we are having the combinations these days. For example, measles rubella vaccine, measles mumps rubella vaccine, measles mumps rubella varicella vaccine, right? These kind of combinations which these days we are available with, right? So this is the measles containing vaccine also we are having these days. But however guys, what is the dose of these vaccines? What is the dose of these vaccines? So basically this is the same guys, 0.5 ml subcutaneous, which I have told you in the chickenpox virus also, that vaccine. So here also the dose is same, so nothing new over here. 0.5 ml subcutaneous vaccine will be giving. Okay, where you will be giving? In the right upper arm I will be giving. In the right upper arm I will be giving. Okay, at what time you will be giving? I will be giving it at 9 months, and then I will be giving it at 16 to 24 months. Okay, I will be giving it at 9 months, and then I will be giving it at 16 to 24 months. Okay, okay guys, so once we are clear with that, right? So what about the doses, right? If we talk about the MCV, measles containing vaccine, okay, we are giving the 2 doses basically, right? So the first dose will be giving the protection rate for around 95%, right? Not the 95%, I will be calling that as 85%. The first dose protection will be 85%, second dose protection will be around 98%, right? Okay guys, so if we talk about the measles containing virus protection rate, right? Measles containing virus, measles containing vaccine, I would say, first dose and the second dose. First dose and the second dose. In the first dose, it is giving the protection for around 85%, right? And for the second dose, it is giving the protection rate of around 98%, right? There is no need to go for the third dose because already we are getting the 90% of protection rate in the second dose, right? So that is the key thing. 85% in the first dose and 90% in the second dose. That is the protection rate as far as measles containing vaccine is concerned. Okay, what is MCV? Measles containing vaccine, right? Once you understood that, if we talk about the vaccine as such, right? This measles containing vaccine, as I told you, this is the heat sensitive and the light sensitive as well. So this vaccine, guys, is the heat and the light sensitive. This vaccine, guys, is the heat and light sensitive, right? Heat and the light sensitive. Okay, so we should not keep it in the sunlight or something like that. Okay, we should be keeping it in the fridge only, because temperature which we are achieving in this case, that is a 2 to 8 degrees Celsius, plus 2 to plus 8 degrees Celsius. Okay, that temperature we want to achieve over here, right? So that is the temperature which we want to achieve over here. So please keep it in the fridge only. Okay, not the freezer, because if you will be keeping in the freezer, that will be less than 0 degrees Celsius. We do not want that. We want it in the fridge only. So that is around 2 to 8 degrees Celsius, right? So that's why you will be seeing that in the wards, okay, and in the hospital settings, okay, in the different wards there is a fridge already. Okay, there is a refrigerator already for keeping these kind of vaccines, right? Isn't it? For example, you are seeing that insulin we are keeping over there, and there are so many medications also which we are actually keeping in the lower degrees of temperature. For example, rabies vaccine also we are keeping it in the refrigerator only, right? For example, if you talk about the rabies immunoglobulin, right? Okay guys, we'll talk about the rabies in the next section, don't worry about that. Okay guys, once we are clear with that, okay, one more important point which they are asking you very commonly, that is that this vaccine is not following the, do not follow the open vial policy, right? I am writing this in the bold letters, guys. Open vial policy, it is not following that. Okay, so it is not following the open vial policy. Okay, what do I mean by open vial policy? In the immunization chapter I will be talking about that in detail, but here let me just briefing it with few words, that open vial policy basically are we are having some vaccines which are actually following the open vial policy, but we are having some particular vaccines which are not following the open vial policy, and measles vaccine is one of the vaccine which is not following the open vial policy. Basically in the open vial policy is that there are some vaccines which can be used for around 28 days. So those vaccines which can be used for around 28 days, they are following the open vial policy. So open vial policy means it is talking about those vaccines which can be used for 28 days, right? So open vial policy is actually talking about the uses of vaccines for the 28 days, but measles, okay, if you talk about, it should be used within 4 hours after the reconstitution. Okay, you are doing the reconstitution, you are mixing it with the distilled water. After the reconstitution, you have to give it to the patient within 4 hours, right? Otherwise this vaccine will be having no use. Okay, so this measles containing vaccine, right? This measles containing vaccine, basically it should be used within how many hours? 4 hours after mixing, after reconstitution with the distilled water, obviously. Okay, right guys, I hope you are clear with that. Okay, very nice. So we have talked about this thing as well, right? What are the contraindication in what kind of patients we should not give this measles containing vaccine, right guys? So let's talk about that as well. Okay, and then we are done with the measles, right? So contraindications of measles, let's talk about that as well. Contraindications, right, of measles containing vaccine, right? So if you talk about the contraindications, basically guys, here we can say that in the pregnant ladies, in the pregnancy we should not give this MCV, right? In the pregnancy we should not give this because if you are giving this vaccine, okay, it might be causing the teratogenicity for an example. So here we are talking about the contraindication for the measles containing vaccine. We should not give it to the pregnant females. We should not give it to those patients who should be getting the blood products, or we are actually telling the patient that they should not be getting the blood products transfused in them for about 3 to 6 months. So avoid blood transfusion for about 3 to 6 months. So some of the so pregnancy, avoid for 4 weeks. After getting this vaccine, avoid the pregnancy for 4 weeks. Okay. If you talk about the blood products, for example, blood transfusion, okay, avoid it for few months. Avoid for around 3 to 6 months. Okay. So be very clear with that. Avoid for around 3 to 6. MO means months over here, right? Okay. Next point over here, patients are showing the anaphylaxis. If the patient is showing the anaphylaxis, the patient is showing the allergy, right? For an example, basically to the neomycin and erythromycin, right? Neomycin and erythromycin. Why I mentioned these two only? Because neomycin and erythromycin, they are the part of the vaccine. They are the part of the measles containing vaccine. So we should not be actually giving these particular vaccine if the patient is having the anaphylaxis to neomycin or erythromycin, or the patient should not plan for the pregnancy if she is female, and at the same time the patient should not be getting the blood transfusion products, okay, for around 3 to 6 months for the prophylaxis purpose, right? Now we are done with the measles, guys. Now I am